Excellent. Okay. So you're very welcome to this absolutely exclusive small crowd that we have here celebrating the really, really high standards that we've had this year in our poster presentations. So the college has a tradition now of having posters at conference. It goes back a very long time, and the quality of poster presentations has gone up and up and up year on and year on. And this year is no different. We're delighted to have so many posters, and it's brilliant to have the opportunity to show the work that you've done to such a large audience. We have 1,600 delegates here this year, so an awful lot of them have walked past your posters and read them. And for many delegates, going to the poster section is actually the highlight of their day. So congratulations to all of you. You are all winners, as we say. But moving on to the real winners, we have 11 categories. Now, not all 11 categories are here, so I think we're missing 2. So we'll march quickly through them all. And what we'll do is I'll call up the first category, and we'll do a wee round of applause, and we'll allow them to present for 2 minutes. There'll be a minute of questions, and there'll be a quick photograph, and then we'll move on to the next. Okay? So the first category is Adolescent Health, and I'm delighted to announce the winner of the Cathy Phipps Award is to Harpet Sush and Josephine Squire.
Hello everybody, my name's Dr. Josephine Squire and this is Harpreet Such, and our presentation and our poster was called Sex, Teenagers and Myth-Busting Education, and I guess you can guess from the title what it was about. We aimed really to go and interact with teenagers and try and find out what their level of understanding was around STIs and safe sex. And to do this, we found we actually needed to go into where they were. So we went to their colleges, we set up stands in their recreational areas, and we went and interacted with groups of the teenagers face-to-face. So these were 16 to 18-year-olds, and we deliberately targeted populations with lower socioeconomic opportunities. We talked to them and we found out that actually a lot of these still don't know very basic information around safe sex and STIs.
So in terms of when we were speaking to them in their lunch breaks, and we were actually using real-time feedback via a QR code. So they were using their smartphone to answer a 10-question survey in terms of what they knew before the session and what they knew after we'd had a brief intervention and given them some more education. And we were actually using this real-time feedback to see where the gaps of knowledge were, so whether it was knowing more about STIs, contraception, access to local services, and actually guiding what we were telling them according to those results. As you can see from our results, 22% of students weren't aware of STI symptoms prior to the session, but this went up to 90% of students knew got more confident recognizing symptoms after the session, and 98% of students felt more likely to seek help after meeting us. So you can see that from the pie chart that the awareness of local services went up after we'd had that brief intervention with them.
And one of the main things we found is actually there are lots of services available to teenagers, but we can't get the teenagers to the service. What we really need to try and do is take the service to the teenagers. Thank you.
Thank you for listening.
Any questions?
Did you deal with contraception as well?
We did, yeah. So we were talking about STIs, contraception, the types of contraceptions available. I think a lot of teenagers weren't aware of the different types of contraceptions, so it was quite a good experience for us to tell them about the LARCs as well. So yeah, we did cover that as well. Any further questions?
Thank you very much for that presentation. When you talk about the teenagers, the age group of the teenagers we're referring to, we'd like to know.
So we went for 16 to 18-year-olds because we targeted colleges, and part of that was actually getting into school proved quite difficult. They have quite strict sex education, and under 16 there was a lot more sort of red tape to go through, so we thought we'd start with colleges, and we found actually there was a lot of easier access there. Thank you.
Well, thank you.
Oh, yeah. Okay.
So congratulations, that was an absolutely fantastic paper and we have a lot to learn from it. So the next category is audit and practice survey. And I'm delighted to announce this is a student presentation. Absolutely fantastic paper in a really complicated area. And the title of the paper was Hypertension Management, Are We Overtreating Patients Aged 80 and Over? And our winner is Alexandra Shields.
Hello, I'm Alexandra Shields. So my audit was about, are we overtreating hypertension in the over 80s? So I did a practice survey in the practice that I was working at, identified all the patients who were over 80 and who had a diagnosis of hypertension, and then found out how many medications they were on to treat their hypertension and how often were we monitoring them. So I identified 233 patients, and then out of this took a sample of 78 patients. So the vast majority of these patients were on between 1 to 3 medications to manage their hypertension, and almost 10% of these patients, their average blood pressure was over 171 systolic. So that highlighted to me that in those cases we weren't managing their hypertension, and actually we were probably causing them more harm by giving them all these medications than benefit. I also found that a lot of these patients, despite taking these medications, were not compliant with their medications, which leads me on to one of the main conclusions that we found is that the over 80s is such a broad group of people, a diverse group of people. There can be over 80s doing parkrun, or there can be over 80s in a care home. So more than other age groups maybe, and we really need to take a patient-centred approach and discuss with them what they want from their treatment. Do they want to be taking medication? Are they at risk of falls? Are they finding side effects? Are they even taking their medication? We found, for example, that some people couldn't open the bottles or disperse their own medication, so they weren't taking it, which is some cases were why their blood pressure wasn't being managed. It was a really interesting survey to find out why these patients maybe weren't being managed, but also to discuss with the GPs of how we can improve this. So we decided that as a starting point in their annual reviews, we would look at this in more detail.
Thank you. I have a question.
Thanks very much. Within your practice that you're working at, who was managing the hypertension? Was it the doctors doing it, the nurses, HCAs?
It was the doctors.
Doing every annual medication review for hypertension in the over 80s?
In our little practice, it was the doctors who were doing it. They were going to the nurses for their blood tests and often for their blood pressure monitoring. I actually found that we were really over-testing their renal function. The NICE guidance is that you test them once a year. Even I think sometimes in the over 80s that even may be too much if they're managed, but the most common number was that we're testing it within every 3 months, their user needs. Probably because of other reasons as well, but I think often you get focused on managing hypertension, or maybe in some practices it's a practice nurse or someone managing that, and then we're not really linking up with then someone else is managing their diabetes, so we're not really linking these things together. So if these patients were on between 1 and 3 medications just for their hypertension, as well as everything else for everything else, most of these patients had other things, diabetes, etc., so on so many medications.
Wonderful piece of improvement work. Thanks.
Thank you very much. Can we get a photograph? Okay. There you go. So, moving swiftly on, our next category is, just checking. Yes, the next category was clinical. and the title was Developing a Pathway for Primary Care for Patients Experiencing a Flare of IBD in Areas Where Rapid Access to Advice from Secondary Care is Not Available. And our author is Kevin Barrett.
Thank you. There we go, that's my slides. So inflammatory bowel disease is one of the conditions that affects a lot of people. The prevalence is rising. It can be as high as 1 in 100 in some parts of the UK as well. Nobody knows what causes it, why it happens as well. Patients often have flares of their IBD, and in lots of areas of the country they have fantastic support from their inflammatory bowel disease team. So you've got IBD nurses and the consultants and the gastroenterologists that look after the patients, support them, give them updates, tell them what to do in case they have a flare as well. However, in parts of the country we don't have that. So when we did our Spotlight project, we said to our GPs, April 2017, how many of you are actually confident in managing your patients with IBD? And we had 525 people respond to that survey who were GPs in training, so quite a decent number. And half of them said they weren't confident in managing their flares. The IBD standards, published only a few months ago as well, said actually all patients should have a flare pathway with them as well. However, we know that lots of patients still rely upon their GPs for their flare management as well. So we got together a team of gastroenterologists, patients, IBD nurses, we had a pharmacist involved with it as well, to co-design and co-produce a set of pathways so that when patients come to us as GPs and we can't get access, we can't get the advice from their IBD teams, we can actually recognise, A, is it actually a flare they're having? Obviously patients get IBS type symptoms with their inflammatory bowel disease, and sometimes they call that a flare, but there's actually no inflammation going on as well. So the pathways tell us what to do recognise, do blood, maybe calprotectin if that's available to us, and look for red flags as well, because obviously patients with IBD can develop bowel cancer and other symptoms and other conditions alongside it as well. It then talks to them about what they should do with the medication. So straightforward things that we as GPs can do to increase mesalazines if you've got ulcerative colitis, for example. Not go straight for steroids, because obviously we know that steroids, overusing steroids are bad for patients for all sorts of different reasons as well. The pathways are now produced, they're on the toolkit. You can download them from our website and the toolkit on there as well. Thank you.
Thank you. Any questions?
So I find this fascinating because I work in an area in Northern Ireland where, well, in fact, most of Northern Ireland has a very long waiting list for anything, and we have a 5-year waiting list for gastroenterology. So I'm wondering whether built into this you had rapid access to opinion or help for GPs with the gastroenterologists. So the patient self-help end is very good, but was there any, from a GP perspective, a rapid access for opinion for consulting?
So the flare pathways are actually designed for patients who've got established, uncomplicated, simple, straightforward IBD. They're not for patients who are on biologic medications with stomas, those sorts of things, not for children, because those groups are often too complicated as well. And again, these pathways are could do's, not should do's for GPs, so I'm not saying that GPs should do that as well. There's a lot of work going on to redesign the care pathways around, and the toolkit has information about that as well, has example care pathways and examples of work that's gone on around the UK for that too. So we can put you in touch with those groups to actually help that.
Yeah, it's probably there for now. So our next category is in education, and our title of the poster was Medicine on the Margins, Learning Opportunities for Undergraduates within Inclusion Health. And our author is Monica Sharma.
My name's Monica, I'm an F1. I recently completed an Inclusion Health elective as a 5th year medical student based in Norwich with a few other students as well. I hope to, with this poster, to do two things. Number one, to provide students and medical educators sort of creative suggestions as to where students can gain greater experience and exposure to marginalised groups. And second, to sort of evaluate medical students' electives using qualitative questionnaires. So firstly, defining Inclusion Health. Inclusion Health is a social justice movement that aims to prevent and address harms from extreme inequity through research, policy and practice. During our time here, as you can see, there's lots of areas that we were sort of exposed to. There's around 10 third sector and NHS organisations that we either participated, observed or volunteered at. Just to point out a few, we were based at Norwich City Reach, which is a practice, and we sat in with GPs, with nurses, with mental health nurses, spent a lot of time with support workers, doing home visits to vulnerable asylum seekers in the community. We volunteered at New Roots Integration, which is a charity sort of providing support for asylum seekers again. And further down you can see Bishop Bridge House and Highwater House, which are homeless hostels, and we learned about the concepts of trauma-informed care, adverse childhood experiences, the long-term impact of that on somebody's life course, as well as concept of dual diagnosis. Overall, students found this a very positive and beneficial learning experience. As you can see from some of the quotes at the bottom, it was a very insightful and unique experience with exposure to population groups that they've never had exposure to in other parts of the curriculum. And also quotes here in green, in any specialty there are patients from hard to reach groups, and having more insight into the lives and the struggles of these patients would make doctors respond more effectively to the needs of these patients. So just to summarise, really beneficial and important learning experience for all medical students, and especially in today's society as we are seeing increased number of homeless patients dying. Last year was a record number. The number of people accessing food banks is increasing. You can argue that there is definitely a need for medical students to have these experiences to be able to address the needs more effectively. Thank you very much.
Thank you. Any questions? Raise your hands. Granny's hand goes up.
I think this is absolutely fascinating. I just wonder, this is about medical students, but there's lots of established doctors working in the health service who have absolutely no experience of Inclusion Health at all. And I think it's brilliant that we're doing it with our students, but I'm just wondering whether there is opportunities for grown-up doctors to participate in a similar type of project.
Definitely. I think what I'm trying to focus on is mainly the medical students, because I think the quote over there really nicely sums it up with patients. They come into all sort of areas of the hospital from very quite vulnerable backgrounds with so many complex needs, and doctors aren't often well equipped to understand and to address these needs. There is some really interesting work going on with, as I'm sure some of you are aware, with Dr. Austin O'Carroll, which is the inspiration I took from the title Medicine on the Margins. He did a TED talk on that, so if you haven't seen that already, I really strongly suggest looking that up. But he is pioneering a GP training scheme, particularly for GP trainees to have exposure to and sort of work together with vulnerable groups. So, thank you.
So our next category is around emerging technologies, and our poster title was System-Wide Perceptions on the Use of Telemedicine in Care Homes, and the author is Joanna Smith.
Hi there, apologies, I don't have a slide because I only actually found about 15 minutes ago that I'd won. I'll just talk you through a little bit in terms of what we did. So we did a short survey looking at perceptions in telemedicine before and after the implementation of telemedicine in Croydon. the survey was intentionally incredibly short because we know you're all incredibly busy, and it was an online survey sent out to both GPs and care homes. The aims of the survey were really to look at general attitudes to telemedicine, because we understand they're very varied, looking at whether or not the implementation of telemedicine had any effect on the perceived quality of care in care homes, and the last question was about the effect on workload, both for GPs and in terms of care home staff, of telemedicine going into the care homes. In terms of the results, it showed that in terms of the 3 questions that we asked, general attitude increased from before to after, the 6 months after the implementation of telemedicine, whereas the quality of care and the workload both stayed the same, so both didn't have an effect on either of those. And remember, this is perceived, this is not a discussion about whether it actually did or did not have an effect on the quality of care. In terms of what we thought was quite interesting from this study was looking at the fact that implementation itself had a positive effect on GP attitudes, particularly in terms of when telemedicine was implemented, GPs liked it more than they had done prior to the implementation of telemedicine. And the other thing was the response rate from the care homes greatly increased from before to afterwards from this online survey after we'd implemented. And that went along with the fact that actually lots of care home staff were incredibly keen about this. So after they started using it, they really enjoyed the fact that they had online immediate access to help. We didn't go too much into the activity data, but it does show that the homes that are using it more are getting bigger results in terms of looking at call-outs to GPs, looking at call-outs from ambulance, an increased rate of... And that was correlated with the fact that actually in those areas where care homes weren't using it quite as much, GPs' attitudes in those areas were either more ambivalent or slightly negative to the telemedicine. There's lots of work ongoing. It was a small study in terms of limitations. It was a very small study of about 15 GPs and 15 care home staff responding to the survey, and the short timescale. So it's only 6 months that it's been in place that the survey was done. Future work in terms of what's happening with telemedicine in Croydon is very exciting. They're doing a new LAS pathway, looking at how to integrate LAS into the care home medicine, as well as looking at how to do remote care home assessment using the package that they already have in the care home. So in terms of hospital discharges, looking at how to discharge quicker without care home staff having to come into hospital themselves because they can use the telemedicine. So lots more work going on, and we're envisaging that if we do the survey again, it will hopefully again have changed in terms of looking at attitudes. Thank you very much. Any questions?
Thank you. Any questions for Joanna? Here we go.
How were the care homes using the telemedicine service?
So it's based on one of the vanguards with Airedale, Airedale Vanguard in terms of telemedicine, how they use it there. There's a hub in Airedale, and the care homes pick up the phone or the video link and place a call, and that goes to the hub in Airedale, and they give clinical advice and clinical care. They can either choose to say, yes, a GP does need to come out and visit, or they can choose to say, no, an ambulance needs to be called, or they can deal with it themselves and say, actually, ring back again in 6 hours and we'll take neuro-obs in between that time and we'll see what happens in that. So they take over the clinical care in terms of how the telemedicine works. But the care home staff use it, give a call, that's all they do.
What's yours? So our next category then is in ethics, and the poster title was Ethical Dilemmas Encountered by Career GPs, a Qualitative Study, and the author is Joanna McIver.
Thank you, I'm Jo, and I just wanted to tell you a little bit more about my study looking at ethical dilemmas in early career GPs. So as part of this research, I interviewed 10 GPs, and I was particularly interested in these 3 areas. So first of all, identifying a list of the types of dilemmas these GPs encountered, particularly in their clinical roles. Secondly, considering factors that increased moral distress associated with the dilemma. And thirdly, looking at some of the strategies that these GPs were already using to try to resolve these dilemmas. So some of the top dilemmas encountered including cases where patients were requesting investigations, referrals or treatments that GPs didn't feel were justified, patients declining interventions that the GP recommended, such as admission to hospital, dilemmas around end of life and advanced care planning, and issues of kind of confidentiality between patients and their relatives. Factors that I found that increased moral distress amongst this sample of GPs could be kind of divided in this way. So first of all, patient factors, in particular where there was a mismatch between patients' expectations of the services and services that were actually available. The doctor factors were twofold. So first of all, thinking about the role of the GP in general in society, but secondly, considering the role of the GP as actually an individual with their own thoughts, feelings, emotions. And finally, there were some ongoing concerns about the ongoing doctor-patient relationship that made things particularly difficult to resolve. Finally, some of the key strategies that we used to resolve dilemmas included communication skills, trying to come to a shared decision with the patient, and seeking support and discussing advice with GP colleagues. And in the case of GP trainees, that was also talking to their supervisor. So I'd like to thank my supervisors at Warwick Medical School and also to all of my participants. Happy to take questions, and I've put my email address at the bottom as well if there was anything extra anyone wanted detail for.
Okay, any questions then? Okay.
No.
Oh, thank you. Oh, yes, yes, we do.
And did the GPs let you know what they found were the most effective ways for dealing with these kind of issues? Because we have to deal with them all day. So
so I think it was partly dependent on exactly what the dilemma type itself was. Those kind of three that I put there were ones that just kept coming up again and again, regardless of the dilemma type, and across more than one of my participants. But yeah, certainly going to look into that in a bit more detail. Thank you.
So our next category is in innovation, and the title was Integrated Care is a Reality in Islington, a proactive identification and intervention service for people with moderate frailty. And the author is Craig Seymour.
Sneaking up behind you. I'm worried about Helen. I was in my practice signing a prescription for antihypertensives, as in Alexander's practice. And I haven't seen Helen for a while. She used to come in a lot with Paul, her husband. He died a couple of years ago. Helen must be about 80 now. I think she had family nearby, but I don't know how she's getting on. I saw she came in to see the healthcare assistant a couple of months ago. Said she was having problems with her hearing. God, I must remember to ask her about that the next time I see her. The next time I thought about Helen was when I got the hospital discharge summary. She'd fallen over at home. She'd come out of her flat on a dark evening and tripped on the stairs. She's broken her hip. She's not sure she'll manage back in her flat. She's going to move to a care home closer to her family. That's the story of Helen. My name's John Mcgrath. I'm not Craig. Craig couldn't be here today. He's off doing an MBA. But about 18 months ago, I was a clinical fellow in frailty with a background in quality improvement working in Islington in North London. And myself and a whole group of people got together and thought, what could we do differently for people like Helen? People who we don't know what they might need help with. Something that was innovative, something that was integrated, something that was proactive. And so we got together and we used the EFI tool, which is being used for frailty in clinical practice. We used it across 9 GP practices. And we asked GPs to tell us who was definitely frail, who was already known to services in the system. We asked them to tell us who definitely was not frail. And then we wanted them to give us everyone else, people who were in the middle, people who were just about managing, or people we didn't know anything about. And then this wonderful group of people went to work. This is an innovative collaboration of people who work for different organisations. The Acute Hospital Trust, community providers, the voluntary sector, and a GP with special interest in older people. And this team worked together as one team on behalf of general practice, writing in the same clinical notes as the rest of us, going out and contacting people. 900 phone calls and 400 home visits later, we've done some good stuff for patients. I'm not going to show it on this slide. It's in the poster, and it's in a couple of publications we've done about this. We sorted out stuff that could be sorted out quickly. We sorted out people's housing situations, got the lift fixed in council buildings, put new bottoms and walking sticks where that could be done, and referred on to local services where that was the best thing for people to have. We used QI methodology and evaluation from our Federation Quality Improvement team, and Public Health came in and evaluated us as well. We got visited by NHS England, and the quote at the bottom is, "Nice to be told that what you're doing is world class and world leading in proactively segmenting a frail population." But the main output of it is that local GPs get to be a little bit less worried about people like Helen. Thanks.
Do you have any questions?
Sorry?
No? Okay. Oh, so we have one in the front. Hang on. Yeah. Back on.
Did you involve, how involved was the usual GP in the notes entry and the clinical review and the care planning?
So the priority that we got asked by the local GPs is not to make any extra work for them. Yeah. That was the absolute gold dust of doing this. So the local GP was paid for their time in evaluating the EFI list. That doesn't get done everywhere, so they were paid for that in this project. But thereafter, the proactive intervention was done by this community team who could read and write into the notes, including creating those care plans. There, of course, then will be actions that get taken back into general practice as a result of that, and the idea was to try and manage that in such a way that it didn't increase workload. And our satisfaction that we've got back from both clinicians and mainly from patients has been extraordinary.
Okay, so the next two prize winners are not actually with us, but I think, are we going to mention them anyway? Think so. The international poster was won by Sonny Ung for developing quality general practice in Myanmar. And the quality improvement winning poster entitled GP Consultant Exchange Programme and Observational Study from Wessex was won by Priti Agawai. So moving on, then the next one that we have here today is the research paper. And this was entitled, What is the Role of General Practitioners, GPs and the Primary Care Team in Palliative Care for Children? And the author was Stephanie Harding.
So these are some quotes from our research. What has had reflection on the profession? So in this research, we explored the views and experiences of children with life-limiting and life-threatening conditions and their families in order to understand when and how palliative care can be delivered more effectively for them. These are quotes from some of the family members. And most reported that the support from their GP was practically non-existent. So the number of these children are rapidly increasing. Their conditions are long-term, complex, highly unpredictable, and they almost outnumber GPs in the UK now, 2 to 1. So the families interviewed were facing one of the most difficult situations that any family can face in their lifetime, the possibility that their child may die. And those that took part in the research described the importance of feeling heard and respected with professionals who were accessible and compassionate. These are core skills of a GP, but yet they're not being felt. But it doesn't have to be this way. The children and their families expressed a desire for someone to check in on them, someone phoning them up and saying, "How are you doing? Do you want to come in and have a chat?" Perhaps to call monthly to address the space between hospital appointments when they say no one knows what's going on in between. Some families use chronic disease and learning disability reviews as an opportunity to foster the relationship with their GP. And for some of them, just having the pharmacist proactively managing their medications and repeat prescriptions, so they're not spending every other day at the GP practice saying, "I need this medication, I need that, oh, you have to go to the hospital," has such a big impact on their lives. So, national policy and quality improvement initiatives in palliative and end-of-life care both specifically mention children. So when you return to your practices, please remember this talk. See if you can identify the 2 children in your practice with life-limiting and life-threatening conditions, and just adding them in your palliative register and considering their family needs. And you may be surprised at the impact you could have on their lives. Thank you.
Okay, do we have any questions at all? Yes.
Thanks. So what was the sort of local palliative care service, not GP, so the hospital provided or community provided palliative care service within your area at this time?
That is a good question. So I think it was a bit broader than that. It was so obviously most of these children are being seen. There's such a wide range of conditions. Some of them are being seen in hospital by specialities. Some of them are in hospices. I think it's kind of hard to encompass. It's all in the West Midlands, so the services did vary quite a lot. But it was over the last 2 years. I can't tell you more about that, unfortunately. Quite a variety, basically.
Sorry, I guess what I was asking is, was there literally no one touching base with these children and families in contact at hospital, or is this a gap in service provision by general practice, or was there some sort of alternative service providing a service?
It's the usual thing where a child may have a really complex condition. They'll have their, 3 different consultants on it, and they're all looking at a very specific part of the treatment. And everything is very segmented, and no one, if you ask, the neurologist about the kidneys, they'll say, oh, go and talk to that. They need the GP to be like, how are you actually coping? Like, aside from the chemo and the scans, how are you coping? How is the family doing? And the repeat prescriptions was a really big thing. The hospital would prescribe a medication, and the GPs say, oh, I don't want to touch it. I'm not putting it on your repeat. That's not licensed, etc., etc. So these parents going every other week to hospital, back to the GP not listening. It's all just a bit of a mess, basically. I hope that answers your question in some way.
Any other questions?
Okay, thank you.
Okay, and that brings us to our final paper, which is in the area of service delivery. And the winning poster was called "What do GPs identify as support and resource needs when caring for communities affected by female genital mutilation?" A qualitative research study, and the author is Sharon Dixon.
Okay, thank you. So FGM, as I'm sure you all know, is all procedures that alter or injure the female genitalia for non-medical reasons. There are no benefits and many documented harms. It's an ancient cultural practice, but it's been the subject of quite recent policy and media scrutiny, a lot of which is relevant to us as frontline professionals. There's been a very welcome focus on safeguarding and care needs, but there have also been policies which are quite unique to this area, including a mandatory reporting duty for GPs in England and Wales requiring disclosure of known FGM in girls under 18 directly to the police, an enhanced data set for GPs in England requiring quarterly submission of patient identifiable details without consent to NHS Digital. I was involved in a patient and public involvement project that identified the potential impacts of these policies on trust and communication in healthcare as a research priority. Actually, worldwide, we're not aware of any published research about primary care perspectives or understandings about caring for these communities in nations where there's been migration. So it felt like quite an important thing to look into. So we went out and we spoke to 17 GPs from 5 cities around the country with a range of experience of encountering FGM from never, rarely to often. And we gave them a scenario to give them a safe space to think aloud about considerations and things they might think about. There's a lot more to say, and it's on my poster, but some key things that came up were thinking about how and when to talk about it, and that's quite represented in literature from obstetrics and gynecology in terms of language and culture and sensitivities and fear of offending. But there were some unique new GP things, like, but why is she here, and is it relevant, and how can I introduce it into a conversation because of policy when the conversation's actually about something else and about her needs. A really strong thing that came out was about the primary care perspective of dual responsibilities. So the fact that for the woman who presents, she may well have other family members who are also registered at the practice. And One GP talked about it as an expanded risk scenario which could balloon out of all proportion. You've got the care needs of the woman in front of you, and then you're thinking, what have I missed? What do I need to do about her mother? What are the ethics? How do I get her sister in? Who else do I need to talk to? Where are the resources to help me do that? How do I manage those dual responsibilities? Where does that lie in primary care? And then a lot of reflections on the recording and reporting responsibilities that were perceived as making an already complex conversation perhaps more challenging and more difficult. It's hard enough to get a qualitative research into 2 minutes, so I'm going to stop at trying to introduce sociological theory, but I have used Lipsky's theory of street-level bureaucracy to help make sense of how GPs have enacted this policy in a way that helps them salvage their decision-making and service values. And that's primarily been about primary care relationships, about the things that we value in primary care, and it's about having services and things of value to offer women that justify opening up a difficult conversation. Thank you.
Okay, do we have any questions? Yeah, we got one on the front. Just to say as well, the photographer has asked if all the winners could stay behind just to get a big picture at the end, if that's okay.
Are there any sort of practical tips around language that we should be using to try and sort of start the conversation in practice?
Yeah, there are some very good guidelines. Actually, I have to say the Electronic Learning for Health module that uses patient experience for talking about FGM, I thought was really helpful about talking about FGM. I think there are some pitfalls and challenges that also came up in my work and some of the other project work I've done, which is about what terms you use and which communities align which practices as FGM. So some practices that we would consider FGM, like labial elongation, may not be aligned with FGM by the communities who practice them. So there isn't a one-size-fits-all solution. I think generally all the things we do in usual, the kind of respectful, straightforward language, watching for cues, seeing how things are received, often cut or closed, if that's the right word in the right community. I think it's important to know a bit about what type of FGM might be relevant to the woman you're talking to, if that's possible, because then you've got a better chance. But, sorry, that's a bit of a vague answer, didn't particularly come out of this.
Any other questions?
So I probably should just say also that I am actually a trustee of an anti-FGM charity. I don't know how important my conflict of interest is. I'm not sure if it's a conflict or an interest. But
I'll just say thank you very much to everybody for your attention. This is a really interesting session. A huge amount of posters still up ready for your reading. And do spread the word to your colleagues about entering posters for the college competition. It is a huge way to share your learning. Thank you.